Hello everyone, welcome back. Today I am going to cover regarding pathological fracture. Starting off with an introduction, histopathology, biopsy, impending pathologic fracture, Harrington and Mirel classification, pathologic fracture, survivability, surgical oncology, and lastly regarding radiation oncology. Definition of pathological fracture. It is a fracture that occurs through a diseased bone. Pathologic fracture can be preceded by lesions producing a prodromal pain or can be indolent until the time of fracture. Patient may or may not report a red flag symptoms. Example, loss of appetite, loss of weight, pain or fever at night, etc. Patient may report symptoms of hypercalcemia, which could masquerade as mild confusion, gastrointestinal abnormalities, to cardiac arrhythmia and renal failure. Histopathology. Histology varies based upon the source of the primary malignancy. In general, lesions are graded as low, intermediate, or high grade. The grade of the lesion is determined by the degree of cellular atypia, pleomorphism, active mitosis, matrix production, and necrosis. Lower grade lesions are biologically less aggressive, while higher grade lesions are more aggressive and hence prone to further spread and metastasis. Biopsy. It is performed following a completion of laboratory and radiological workup. There are 6 recognized reasons to complete a staging workup prior to biopsy. Number 1, the tumor may be a primary bone sarcoma. Therefore, a staging workout would prevent poorly placed biopsy location or trajectory. Number 2, there may be an additional site of metastasis that is more easily accessible and or associated with less morbidity than the site of the pathologic fracture. Number 3, preoperative embolization may be required for intraoperative hemostasis. Number 4, an unnecessary biopsy may be avoided altogether if the diagnosis may be made via laboratory analysis alone, such as with multiple myeloma. Number 5, histologic analysis in isolation identifies only 3% of cases. Number 6, a combination of preoperative imaging and laboratory studies with histopathology increase the likelihood that the correct diagnosis will be made. For impending pathologic fracture, an impending fracture is a biomechanically weakened area of bone that has fracture risk higher than for a less force that would be required for the normal bone to fracture due to pathophysiology of the underlying lesion. For example, normal weight bearing through a pathologic lesion could lead to pathologic fracture due to the biomechanical fragility of the surrounding bone architecture. Two recognized classification system for impending pathologic fracture. Number 1, Harrington criteria was first described by Harrington et al. 1980 to determine the indications for prophylactic internal fixation. Harrington criteria based on 4 parameters. Lesion involve more than 50% of cortical bone. The lesion is greater than 2.5 cm. Presence of pain following radiotherapy, and fracture of the lesser trochanter. Limitation of this classification: it only applies to the proximal femur and does not account for disease-specific tumor pathology. This picture figure illustrates the Harrington classification. In this figure, it is divided into class 1. There is disruption of lateral cortices with intact superior and medial wall. The treatment is conventional acetabular component. In class 2, there is a deficient medial wall and the treatment involves medial mesh. For class 3, there is disruption of lateral cortices and superior wall. The treatment involves acetabular cage with long screw fixation plus or minus cement augmentation. For class 4, there is pelvic discontinuity, where the treatment involves saddle prosthesis or resection arthroplasty. Buat sebelum ya. Number 2. Mirel classification was first described by Mirel in 1989. The study was a retrospective analysis of 78 lesions of long bones that had undergone radiation therapy without prophylactic internal fixation. This scoring system has a maximum of 12 points, with more than 8 points indicating the need for prophylactic fixation. This figure illustrates the Mirel scoring system. For site, 1 point is for upper limb, 2 points for lower limb, and 3 points for the peritrochanteric region. If mild pain is 1, moderate pain is 2, and functional or severe pain is 3 points. Blastic lesion is 1 point. Mixed lesion is 2 points. Lytic lesion is 3 points. If less than 1/3 involvement is 1 point, 1/3 to 2/3 involvement is 2 points, and more than 2/3 is 3 points. An alternative scoring system such as CT-based structural rigidity analysis, CTRA. A study by Damron et al. In 2016 evaluates the CTRA compared to Mirel's criteria in pathologic femoral fracture and found CTRA to have a higher predictive value in identifying an impending fracture. The benefits of prophylactic fixation of an impending fracture include: elective fixation removes the pain and morbidity associated with a true pathologic fracture, and it facilitates a easier surgical management. Pathologic fracture. The treatment of pathologic fracture is dictated by the pathophysiology of the causative lesion and expected survival rate. Altered disease biology leads to decreased or destroyed fracture healing potential. For example, the fracture healing rates for metastasis from multiple myeloma, renal, breast, and lung carcinoma are 67%, multiple myeloma, 44% renal, 37% breast, and 0% for lung. This variation of fracture healing potential across different malignancies highlights the importance of proper diagnosis of the primary lesion for successful preoperative planning. For example, a fracture through a lesion secondary to myeloma has greater healing potential than one secondary to lung carcinoma. Therefore, a construct involving plates and screw might be sufficient for a myeloma fracture, whereas more extensive bone-replacing prosthesis would be necessary for a fracture caused by a lung cancer. For renal cell carcinoma, metastasis should be widely excised when possible. A review revealed a statistically significant improvement in cancer-specific survival, 4.8 years versus 1.3 years when complete metastasectomy was performed. Higuchi et al. Shows improvement in overall survival and recurrence-free survival for patients undergoing wide resection as compared to local curettage. This study revealed that intralesional resection was independent risk factor for poor prognosis and was associated with significantly more intraoperative blood loss. Survivability. 6-month survival rate for prostate around 98%, breast 89%, renal 51%, lungs 50%. 5-year survival rates for localized soft tissue sarcomas are 83% versus 60% in systemic disease. Additionally, activity levels must be taken into account. A patient who is in wheelchair or bedbound requires different fixation than a patient still ambulating and or weight-bearing through the involved extremity. Surgical oncology. Surgical intervention for a pathologic fracture should only be considered following full oncological workup and biopsy of the lesion. Implant selection should generally adhere to the following guidelines: load sharing as opposed to load bearing or load sparing when possible. The example is interlocking nail. This X-ray shows an example of interlocking nail done to fix a fractured femur. Durable implants with the goal of lasting the length of a patient's survival with the disease progression. Immediate stability allowing for immediate weight bearing. The length of implant should bypass the lesion by 2 cortical diameters. The usage of cement augmentation when necessary. Lastly, regarding radiation oncology. Radiotherapy is generally performed on an adjuvant or post-operative basis to prevent local disease progression. Radiosensitive tumors include multiple myeloma, lymphoma, prostate, breast, ovarian, and neuroendocrine. Radio-resistant tumors include sarcomas, renal, thyroid, hepatocellular, colon, lung, and melanoma. Radiotherapy can be used in severe comorbidities or poor prognosis patients. Yay! We have reached to the end of this video. See you in the next one. Take care and bye.